Hope you all are good, you all are fine, you all are fighting for your goals. And we are back with another live session. And today we are supposed to do ALL. So there was a morning session that was scheduled, and in that session we were supposed to do splenic enlargement or splenomegaly. So basically वो session नहीं हो पाया है, but either in the next session or tomorrow we will reschedule that session and we will complete that, right? So today we will be doing ALL and CLL, right? So कुछ important emergency आ गई थी, so have to look after that patient. So जाना पड़ा था मेरे को, so that's why मैं क्लास नहीं ले पाया. हाँ, so we are live. I don't know what's wrong. थोड़ी सी क्रैकलिंग सी साउंड आती है. I don't know what's wrong with this laptop, और इसका स्पीकर जो है उसमें क्या प्रॉब्लम आ गई है. Everything is looking fine. Yeah. So now let's start the topic. एक बार webcam सही है या नहीं वो देख लेते हैं पूरा. So guys, welcome to Unacademy. I am Shiv Virmani, MBA student, author of the book Pharmac Easy, and yeah, welcome back. So you all must be knowing how to install the Unacademy app, or you all must be having Unacademy app on your mobile phones or iPads. And अगर आपने install नहीं कर रखी, then you can right away type Unacademy on App Store and Play Store, and you can easily install this app from these two. हाँ, ये दोनों है तो यही दोनों से कर सकता है. It is free, and you, even if you don't want to buy the subscription, even if you don't want to buy the plus course or the iconic course, then also you can use it for free. You can attend the special classes, you can chat with the educator, you can clear your doubts, right? Plus, we are having top level of educators from AIMS, Safdarjung, and all the esteemed universities. And we are having two choices for the medical student to clear or to crack the NEET PG. First is plus course and second is iconic course. So plus course lets you to attend live classes, live tests. You can take quizzes, batch courses. You can enroll in the batch course. You get the structured schedule, and yeah, I would suggest this to all the medical students. And now comes the iconic, that is the collaboration of Prep Ladder and Unacademy. So in this iconic, you get all the benefits of Unacademy, plus you get the benefit of Prep Ladder as well. You get the access for pre-recorded video lectures. You can take, or you can look up to the Q bank of Prep Ladder. You can revise the course because you get rapid revision course, then handwritten notes. So if you are a second or third year medical student, then I would rather refer or prefer you this iconic course. And iconic course के अंदर you have 4 choices: 12 month, 18 month, 24 month and 36 months. And If you want to buy this, you can use the code VIRMANI and you will be getting 10% off. And if you want to buy the plus course, then you have many choices. You can buy it for 1 month, you can buy it for 3 months, 6 months, 12 months, 18 months, 24 months and 36 months, and code is same. And so welcome to the PathoNION, the pathology companion. So here we have to complete the pathology. So we have already started with the hematology, and then we will be jumping to the systemic pathology. And thank you so much for all the love you have showered on the Pharmac Easy series. That was the series for pharmacology. So we have already completed the pharmacology, and response is so good, response was so good, तभी हमने pathology की भी series start करी. And thank you so much for your comments, for your appreciation. And yeah, let's just jump to the ALL. So guys, ALL and CLL. ALL, that is acute lymphoblastic leukemia, and जो CLL होता है, it is chronic lymphocytic leukemia. So lymphoblastic means in acute you will be seeing blasts more, right? So let's just jump to the ALL. Acute lymphoblastic leukemia, and chronic one is called as chronic lymphocytic leukemia. So basically lymphoid malignancy originates from the precursor series of B and T cells, right? So these are only the two cells in the lymphoid series. The lymphoid malignancy originates from these two precursors. In B cell or T cell के precursor से originate होता है, and this is the most common form of cancer of children under 4 years of age, and together constituting 4% of all the lymphoid malignancies. And ALL is the most common type of leukemia that you can find in a child or in a elder male or female, right? So pre-B cell ALL constitutes, so basically दो types में ये divide हो चुका है, because there are two cell lines, so it has been divided into two forms. If the leukemia is starting from B cell, then we will be calling as pre-B cell ALL, and if it is originated from T cell, then we will be calling it as pre-T cell ALL, right? So pre-B cell ALL constitute 90% of the cases, while pre-T cell lymphoid malignancies comprise only 10%. So mostly patient will be suffering from B cell, right? And the leukemia will be starting from pre-B cell or the precursors B cells. And जो T cell वाला leukemia, it will only constituting only the 10%, remaining 10%. This group of lymphoid malignancies arises from the more primitive stages of B or T cells, but the stage of differentiation is not related to aggressiveness. Both these are presented together because of the morphological similarities. So we can, so earlier क्या होता था कि B cell की वजह से है, then we will be calling it as some other, calling it with some other name, right? Because B cell से हो रहा है and T cell से हो रहा है, तो कोई और नाम से बुलाएंगे. But later, as the clinical features are same mostly, so इन दोनों को हमने एक ग्रुप पे constitute करा, that is ALL, because these two comes under lymphoid series, right? Lymphoid series में से they will be divided into pre-B cell and pre-T cell. So precursor B cell ALL और lymphoma के clinical features क्या होंगे, right? So as we have already discussed that it is divided into two, precursor B cell, precursor T cell. So now first let's talk to the precursor B cell ALL or precursor B cell lymphoblastic leukemia or lymphoma. So most often it presents as ALL in children, and rarely presentation may be form of lymphoma in the children or adults, and it rapidly forms into leukemia, right? In cases having leukemic presentation, extranodal site involvement is early, such as lymphadenopathy, hepatomegaly, splenomegaly, CNS infiltration, testicular enlargements, and at times cutaneous infiltration, right? And infections due to cytopenia are present. So generally, basically there will be rarely presentation that will be in the form of lymphoma. Mostly it is in the leukemia, and in cases having leukemic presentation, first of all there will be extranodal site involvement, such as lymph nodes will be enlarged, spleen will be enlarged. You can have CNS infiltration as well, testicular enlargements, and at times cutaneous infiltrations. Then infections due to cytopenia are present. Then precursor T cell lymphoblastic leukemia or lymphoma, as the name implies, these cases may present as ALL or as lymphoma, right? Since the precursor T cells differentiate into the thymus, this tumor often presents as the mediastinal mass and the pleural effusion. So generally a small male or a small child will be having a B cell type of ALL, right? And जो T cell वाले में है, that will be presenting as a mediastinal mass or pleural effusion, right? And it progresses rapidly to develop leukemia in the blood and the bone marrow. Clinical features of the bone marrow failure are present, which include anemia, neutropenia, thrombocytopenia. Then patient will be having lymphadenopathy, hepatosplenomegaly, and CNS infiltration as well. Then precursor T cell lymphoma or leukemia is however more aggressive than beta cell counterpart. So जो precursor T cell ALL है, it is more damaging, more aggressive, and thus prognosis will be poor, right? Poor prognosis. Then morphological features. Precursor B and T cell ALL or lymphoma are indistinguishable on the routine morphology. The diagnosis is made by the following investigations. First is blood examination, then bone marrow examination, then cytochemistry or cytochemical examination. Then there are some other characteristic features, उसके बारे में हम बाद में बात करेंगे. First, bone marrow examination. So peripheral blood generally shows anemia, right, and thrombocytopenia, and may show leukopenia as well, right? So or you can say PBF will show pancytopenia, right? And जो रेशियो है TLC का, तो it will be total leukocyte will be more, and DLC shows large number of the circulating lymphoblast. So DLC is the differential leukocyte count. It will be showing the highest amount of the lymphoblast having round to the convoluted nuclei, high nucleocytoplasmic ratio, and absence of the cytoplasmic granularity. And it is important to distinguish AML from ALL. Then it is usual to find some smear cells in the PBF, and which represent the degenerated leukocytes, right? Then bone marrow examination. Marrow examination shows 20 to 95% of the malignant undifferentiated cells of the precursor B or T cell origin, as demonstrated by immunophenotyping. megakaryocytes are usually reduced or absent. Then cytochemistry. Cytochemical strains may be employed as an adjunct to Romanowski stain for determining the type of leukemia. Then, right, then there are some commonly cytochemical stains that are used. First is PAS, periodic acid stain. So it is positive in immature lymphoid cells in ALL. So it comes positive for the immature lymphoid cells. Then second is acid phosphatase. Acid phosphatase is focal positive in the leukemic blasts in ALL. Then myeloperoxidase. Myeloperoxidase is a negative in immature cells in the ALL, right? But it is positive in the AML, right? Because it comes positive with the myeloblasts. Lymphoblast के लिए positive नहीं होता. Then Sudan black. Sudan black is negative in the immature cells in the ALL. Then non-specific esterase is also negative in ALL. So there are only two things that comes positive in the ALL, that is PAS and AP. Myeloperoxidase, Sudan black and non-specific esterase is negative. Then immunophenotyping. TDT, terminal deoxynucleotide transferase. It is expressed by the nuclei of both pre-B and pre-T stages of the differentiation of the lymphoid cells. Then specific diagnosis is established by following the immunophenotyping. Pre-beta cell type is basically positive for the pan-B cell markers, that is CD19, CD10, CD9A. And pre-T cell type typically involves, or typically it is positive for CD1, CD2, CD3, CD5 and CD7. Cytogenic analysis की बात करें, then leukemic blast in the pre-B cell ALL shows characteristic. So leukemic blast in pre-B cell ALL, so it shows characteristic cytogenetic abnormality for the T922, that is Philadelphia positive ALL. So terminal deoxynucleotide transferase is expressed by the nuclei of both pre-B and pre-T cells, right? Right, and there are specific diagnostic markers, right? अगर pre-B cell का monoclonal proliferation है, then you can find, or you can find these markers positive, like CD19, CD10, CD9A. And pre-T cell type में you find CD1, CD2, CD3, CD5 and CD7 positive. Then cytogenetic analysis की अगर बात करें, then leukemic blast in the pre-B ALL show characteristic cytogenetic abnormalities of the T922, and इसकी हमने बात करी थी, it is a reciprocal translocation, right? And क्या फॉर्म होता है, Philadelphia chromosome, and that is also positive in CML. And so अगर ये abnormality भी you can find this abnormality, then you can say Philadelphia positive ALL, right? And how you will be treating this patient, and how's the prognosis. So treatment plan for the children with pre-B or pre-T cell ALL is intensive remission induction with the combination therapy. So mostly children would be having the pre-B ALL, and the treatment plan is intensive remission induction with the combination therapy, and patient presenting with pre-B and pre-T cell lymphoma are treated as the case of ALL. Then chemotherapy. The most useful drugs in the treatment of ALL are the combination of the vincristine, prednisolone and anthracyclines, and L-asparginase as well. Other agents used are cytosine, arabinoxide, and methotrexate. Though 90% of the children with ALL show remission with this therapy, and patients with T cell ALL and those with meningeal involvement carry a less favorable prognosis. So that will be having a poor prognosis, like I said earlier. Then CNS involvement is beyond the reach of the most of the cytotoxic drugs used in the therapy of ALL. Then CNS prophylaxis in such cases is considered after the initial remission has been obtained and includes cranial irradiation and course of intrathecal methotrexate or cytosine arabinoxide. Then bone marrow transplantation. Bone marrow transplantation from suitable allogenic or autologous donor as HLA and mixed lymphocyte culture match is used in the pre-B and pre-T cell ALL in adults with relapses. Then bone marrow transplantation has resulted in cure in about half the cases. Then prognosis and disease-free survival of the children with both pre-B cell and pre-T cell ALL is better than in adults. And mean survival with the treatment of the children without any CNS prophylaxis is 33 months. While with the CNS prophylaxis it's around 60 months or more. Then adult pre-T cell ALL, however, is as grave as AML, and median survival is of about 12 to 18 months. Then the patients having limited disease confined to the lymph nodes only in both pre-B and pre-T cell type have a higher cure rates and better prognosis because the focus is really small and it is generally stopped before spreading, right? Before the disease that covers the whole body, अगर उसका फोकस छोटा है and early पता चल गया है that it is originating from these lymph nodes, then we can just surgically remove them and we can protect the patient from further metastasis, right? And I hope that so let's just differentiate the AML and ALL first, and then we can end this session here, and we will be meeting today at around 4 p.m. again, and we will be discussing the CLL. So let's differentiate the AML and ALL. So AML key common age is between 15 to 40 years of age and comprises of almost 20% of childhood leukemias. But ALL is most common type of leukemia under 15 years of age, and it comprises 80% of the childhood leukemias. Then physical findings: splenomegaly will be there, hepatomegaly will be there, lymphadenopathy will be there, bony tenderness will be there, and gum hypertrophy. And same, all the general features or physical findings are same. So in ALL, splenomegaly will be there, but massive splenomegaly will be there, hepatomegaly will be also massive, lymphadenopathy will be there, then bony tenderness will be there, right? I have seen a patient of ALL and itni zyada bony tenderness thi that I cannot explain it to you, but if you have seen any ALL patient in your clinics, then you can right. And CNS involvement is also there of ALL, but it is not there in AML. Then laboratory finding: low to high TLC, predominance of myeloblast and promyelocyte in bone and bone marrow, thrombocytopenia is also there, moderate to severe. Then here in ALL, low to high TLC will be there, predominance of lymphoblast in the blood and bone marrow will be there, thrombocytopenia will be there from moderate to severe. Then diagnostic criteria: FAB types are there, and it is differentiated or classified between M0 to M7, and WHO criteria is of more than 20% of blast, but we generally rely upon the FAB types. Then we have FAB types are from L1 to L3, and WHO types are pre-beta cell 90%, pre-T cell 10%, and WHO criteria is of more than 20% of blast, and it is same. Then cytochemical stains की अगर मैं बात करूँ, then it is myeloperoxidase positive but it will be negative. Sudan black positive, this will be negative. NSC positive but this will be negative. Acid phosphatase is positive in F4 and F5. So in this, PAS will be positive and acid phosphatase will be positive but focal. Then specific therapy, cytosine, arabinocyte, anthracyclines and 6-thioguanine. And here, and L-asparginase is also used here. And here vincristine, prednisolone, anthracyclines and L-asparginase, right? So these are the therapies. Then immunophenotyping, CD13, 33, 41, 42. But here pre-B cell के अंदर CD markers will be CD19 and 20. Pre-T में CD1, 2, 3, 5 and 7. And here cytogenetics के अंदर M3 के अंदर T15, 17 and M4 in verse 16. And here you can find Philadelphia chromosome like you find in CML, and you will be saying Philadelphia positive ALL, right? If you find Philadelphia chromosome or if you find T921, then you will be saying Philadelphia positive ALL. And response to the therapy, remission rate is low and duration of the remission is shorter. But here remission rate is high and duration of the remission is prolonged. And median survival is between 12 to 18 months. Here children without the CNS prophylaxis is 33 months, but with the CNS prophylaxis 60 months, and adults are having median survival between 12 to 18 months. And with this we have completed the ALL, and in the next session we will be doing CLL. And thank you so much for coming, thank you so much for being here, and let's end this session here. And if you want to buy the plus course or iconic course, then you can use the code Virmani and you will be getting 10% off. And bye guys, take care, stay healthy, stay safe, and keep fighting for your goals.